So I'm pleased to kick off this session by introducing our first guest, Dr. Jay Butler, Deputy Director for Infectious Disease from the Centers for Disease Control and Prevention, who is joining us by audio only and will speak about the virus, progression, and pathology. Dr. Butler.
All right. Well, thank you, and good morning, everyone. So in the next few minutes, what I'd like to do is quickly give you a situation report, but also talk about the progression of the pandemic and spend a little time talking about the disease itself that we now know as COVID-19. So I think everyone's aware that we're talking about a disease and a virus that were not known to exist only 3 months ago. So much has changed very quickly. This virus was first identified in Wuhan, China, in Hubei province in central China in December of 2019. The initial focus was around a large seafood and live animal market in Wuhan, but it became apparent to health officials in China very early on that this disease was capable of person-to-person spread. As the epidemic emanated out from Wuhan, it also became apparent that it was a disease that was transmitted most likely by respiratory droplets, meaning people who coughed or sneezed were generating basically a spray that could contain the virus and could infect other people, and also had the potential to contaminate surfaces where the virus might remain stable for a period of minutes to days, also creating another opportunity for transmission. The initial cases outside of Hubei province and outside of China were in travelers. So it's important to, again, focus on the fact that this is a disease that appears to be primarily transmitted person to person. The first case that was reported in the United States was on January 21st, so 2 months ago. That was in an individual who had traveled during the incubation period, re-entered the United States, and then developed symptoms. There were other cases related to travel that were identified, and the initial cases that occurred in the U.S. were in household contacts of those individuals. The pandemic has progressed the way pandemics do, with a crescendo acceleration. Globally, the first 100,000 cases took over 2 months to occur. The second 100,000 cases occurred over less than 12 days. The disease has spread truly around the world as well as around the country, although there are some areas where there's more intense transmission than others. Right now, the areas of greatest concern are primarily in Europe, but now here at home in the United States, we are also seeing an accelerated increase in the number of cases that are diagnosed. The greatest level of transmission at this point in time are occurring in areas on the West Coast, also in the Northeast, particularly in New York City, and also in the Southeast, Georgia, Florida, and Louisiana. But I want to stress to everyone that this is an infection that is being seen throughout the country right now. So I think coronavirus is a term that's now become a household word, obviously. A little background on coronaviruses, because I think it can get a little confusing. For people in healthcare, there's awareness that coronaviruses have been around for a while, but I want to stress that this particular virus, the one that causes the disease COVID-19, is new. Everything points to this being a virus that recently adapted to be able to infect humans. It is closely related to the SARS virus, another coronavirus that infects humans. Coronaviruses that do not routinely infect humans actually infect a wide variety of mammals. The most common species that become infected are bats, but there are many viruses that have adapted to a variety of other animals. If you look at your veterinary bill, you may see that your dog has been vaccinated against a coronavirus. That is not the same coronaviruses that cause disease in humans. If you look at a bottle of a household disinfectant or wipes, you may also see that there's indications that it disinfects for coronavirus. That is addressing the previously known coronaviruses, but I want to say right now that the evidence is this coronavirus is also the disinfection for this coronavirus is the same as that for other coronaviruses. The types of coronaviruses that infect humans cause a variety of illnesses from sort of minor cold symptoms, and you may sometimes hear people say that on the media, and that's true. You will also hear people talk about SARS and Middle East Respiratory Syndrome, which have a very high mortality rate. That is also true. The COVID-19 virus appears to fall somewhere between those two extremes. The people at highest risk of severe disease are people who are older and people with underlying chronic heart, lung, or kidney disease or diabetes. We do want to stress, though, that although people who are young appear to have primarily very minor symptoms, there are cases where more severe infection are reported among younger persons. Among children, the disease is probably the most mild. Globally, I am only aware of one person younger than age 19 who has a documented death due to COVID-19. Let me say, jump to a little further down. So in terms of, we talked about how COVID-19 spreads, and that ties into what we can do to prevent transmission. Currently, there are no FDA-approved mechanisms for treatment. There are a number of trials that are underway, as well as interest in some older drugs that might have activity, and I'm sure people have heard a lot of reports in the media about that recently. There are no protective vaccines now, and I think it's very realistic to say we're probably looking at 12 to 18 months down the road before there is going to be a vaccine that would be effective against COVID-19. The focus then becomes avoiding people who are sick. If you are sick, stay home. This also gets into some of the issues around what we now call social isolation. Again, a term that has been in the public health world for a number of years, but has become a household word. The whole goal here is to limit those exposures to other people where there may be transfer of the virus. I did mention the possibility of contamination of surfaces, and this is where hand hygiene is critically important as well. While under appropriate lab conditions, highly controlled, we can make the virus survive on certain surfaces for even a period of several days. In the real world, it's more likely that it's going to survive for a period of no more than several hours. So when things are touched, particularly high-touch surfaces or surfaces in public areas, it's important to wash your hands frequently, and it's not a splash and dash, but a good 20 seconds with soap and water. And a good mnemonic, if you're like me and in a hurry, is to go through the alphabet or sing happy birthday a couple of times. Also, alcohol-based hand gels with at least 60% alcohol are a suitable alternative as long as the hands are not visibly soiled. It's also important not to touch your face, which I recognize as a habit can be very hard to break. But this is how not just COVID-19, but influenza, a lot of other respiratory viruses are transmitted, that we inadvertently can't resist that temptation to scratch that itch, and if our hands have not been sanitized, it creates the opportunities to inoculate ourselves with respiratory viruses. The symptoms of COVID-19 are something we continue to learn about, and I want to stress that one of the more disturbing aspects of the disease is not just the more severe manifestations, but that oftentimes people have very mild illness. And even it's well documented now that people can become infected and have no symptoms at all. We are still learning what role that type of infection plays in transmission of the infection, and it could be an important role. However, it's important to recognize that people who cough or sneeze are going to be generating the most droplets, so there really is a critical importance to stay home if you're sick and avoid exposure to other people who are sick if that's at all possible. Some of the symptoms of COVID-19 that are most common are fever, cough, and shortness of breath, but I want to stress that sometimes fever is not present at the beginning of the illness. I talked to someone in isolation just a couple days ago with laboratory-confirmed COVID-19, and this young, very vigorous gentleman actually had a couple of days of low-grade fever, had muscle ache, headache. It was enough that he knew he wasn't well. He knew that he had been exposed, and he was very appropriately tested. But other than a little bit of runny nose that may have been allergies rather than this COVID-19, he never developed cough. At the more severe end of the spectrum, some people do develop diffuse pneumonia, and this can require hospitalization and even support in an intensive care unit, and too often it also results in death. We know over 200 Americans have died of COVID-19 so far. Globally, roughly 9,000 people have, and as you may have seen in the news, now in Italy, more people have died of COVID-19 than died in China during the entire progress of the epidemic. The mechanism of death is respiratory failure. The pathology is, if there are providers on the phone, is diffuse alveolar damage, which basically means that the lungs become filled with inflammatory type materials as well as the viral materials. But that is the minority of cases. The interval between exposure to onset of illness is mostly going to be 2 to 14 days, and even more focused during that period from about 4 to 7 days is when most of the onsets have been observed, when there's a very known and discrete exposure that occurs. The prevention guidelines, we've talked about hand hygiene, social isolation. I just want to say a word about the adverse effects of some of the interventions. While we talk about social distancing, we also need to be aware that social isolation is also one of the dangers involved. We also are aware that there's economic impacts of the steps that are taken. So I think it's safe to say the world will never be the same. Everything that is being done, the goal is to save as many lives as possible and to do what's going to be best for our country and our people. And maybe at this point, I will stop. I thank you for taking, I know all of you are very busy. I thank you for the chance to speak to you today. And if there's an opportunity for Q&A, I'd be happy to take your questions.
Thank you, Dr. Butler. There certainly is an opportunity. I believe we have a few minutes, and our process during this webinar is people are submitting questions to the NAIC headquarters. They're reviewing that, and Mike Considine and Andy Bill will moderate any questions that are received. Mike or Andy, how are we doing on questions?
Thanks, Director. We have a couple questions that have been submitted over the Q&A function, but I think first we'd like to open it up to any of our commissioners who are online who can unmute their lines at this point if they have a question for Dr. Butler. Otherwise, we can go to the ones that have been submitted.
Okay, that's 2 steps there. Let's see if a commissioner can unmute a line and then ask a question. Who would like to be first?
This is Mike Conway in Colorado. I have a question related to Italy. From what I can see, it looks like the death toll in Italy is substantially higher than it has been anyplace else. And at least in part, that appears to be due to the fact that Italy is just an older population. But is there something else going on there that is causing that to be the case?
Well, I think there's a number of possible contributing factors to the higher mortality rate in Italy, and I think that's one of them is we always want to look at what are the underlying population demographics, because it has been confirmed everywhere where this virus goes, people who are older at higher risk. The risk of hospitalization and ICU care and death increases after age 60, and it continues to increase with advancing age and is really greatest among people who are over age 80. Another possibility is that there is more limitation of testing, and that they are only diagnosing the very most severe cases. The hospitalization rate is also fairly high in Italy as well, so it seems like it's very plausible that there may be milder illnesses that are going undiagnosed, and that may also be a reflection of the fact that the healthcare system is fairly strained there now as well.
Great question, Mike. Do you have a follow-up to that?
No, that was helpful. Thank you, sir.
Thank you. Any other questions? All right, Mike, why don't you read one that's come in on the WebEx portal?
Thank you, Director. One of the questions is, Doctor, if someone has had COVID-19 and recovers their health, do we know if they could still get it again, or whether or not the first exposure creates immunity?
Yeah, that's a great question, because I say it's great because it's one that we frequently ask as well as we begin designing studies and looking at the dynamics of the antibody response to this virus. At this point in time, I guess there's 2 points to make. One is we are not aware of documented reinfections, but the caveat there is, again, this is a virus that we didn't even know existed 3 months ago. So the amount of time that has occurred for reinfection to occur is fairly limited. What we know about the more common coronaviruses, the ones that cause milder respiratory illness in humans, is there is an immune response. It provides protection for a period of time that may even be for a few years, but over time, that immunity wanes and people can then become reinfected. So I think at this point in time, it appears most likely that once you're infected, it's unlikely that you would become reinfected in the short term, but we don't have confirmation of that. It's also an important question in terms of the ways that we might treat the infection. While we talk quite a bit about different types of antiviral medications, another option is to create monoclonal antibodies. These are laboratory-produced antibodies that can kill the virus. And also using a little older technology is if people who have recovered have high antibody levels, it might be possible to use what we call hyperimmune serum, which, again, people who are older from a medical background are familiar with that concept. So using the antibodies that are produced by someone who has recovered to treat someone who is infected and bring the infection under control.
Thank you, Dr. Butler. I have a question. In our state, we've had employers ask the question if one of our employees is stricken with the virus, and then when they recover, should that employer require that individual to be retested again before they come back to work, and how long is the traditional amount of time that this virus would take to go through someone's system?
Yeah, so again, another very good question, and it's an area where the recommendations continue to change as we learn more about the virus. Early on, when we were really focused on what I'll call containment, trying to completely minimize the spread of the virus, we were focused on getting 2 tests that are negative prior to people coming out of isolation, whether that's at home or in the hospital. As the number of cases increase, that's very difficult to do, and as we learn more about the risk of transmission after recovery, it appears to be unlikely in the vast majority of instances. So one option is to do the 2 tests, but the more common approach now will be if it's been at least a week since the onset of symptoms and at least 3 days since the resolution of symptoms, particularly fever, people can return to work. If there's a situation where the person returning to work may be exposed to people who are at high risk, such as in the healthcare environment, we would recommend they wear a surgical mask until at least 14 days have passed since the onset of symptoms. And that surgical mask is not to protect the worker, but just in case there's any virus that's still being shed, to make sure that as much as possible it's not spread onto others or onto surfaces. One of the tricky things with testing right now, the primary mode of testing is polymerase chain reaction, which detects the RNA of the virus, that is the genetic material. And even after recovery, there may be RNA of deactivated virus that's still present in the nose and the throat. So a positive test does not prove that someone is still infectious. We would assume that anyone who is infectious early in the course of infection is indeed capable of spreading the infection based on what we know about the amount of recoverable virus that's in those secretions.
Okay, thank you, Dr. Butler. I think we have time for one more question. Let's see if a commissioner has a question first. Any commissioner have a question?
Farmer?
Yes.
It's Sharon Clark in Kentucky. Dr. Butler, thank you for being with us. Can you give us pretty much what is the checklist that our medical providers are using to determine if the testing is necessary?
I'm sorry, that was a little garbled. I don't know if anybody may be able to repeat that, or you can try repeating it as well.
I'm sorry. What is the checklist that our medical providers are using to determine if someone should be tested? Are they looking for a fever?
Yes. Thank you. So the criteria that are being used by providers, there is some variability, but our recommendation is to focus the testing on people who have symptoms, except in situations where there's a potential for a high-risk outbreak, such as in long-term care facilities. And the focus really should be on the people at highest risk, such as people who are hospitalized, healthcare workers, or in the long-term care facilities, where we've seen some very high attack rates and some very high severe illness rates as well. The bottom line, though, is that we encourage the clinician to make the assessment, recognizing that a guideline cannot address every situation, and doctors need to have the freedom to be able to practice medicine as best as they can, given some of the limits surrounding the availability of testing. Thank you for that question.
And thank you, Dr. Butler. That was certainly an informative and great presentation with excellent questions. We appreciate your time this morning, Dr. Butler. Thank you very much.
All right, my pleasure.